Okay, guys, thank you for your patience for that slight delay. We got our slides all up and ready to go. So this next session, we're going to talk a little bit about the pediatric experiences from the past year, and offer maybe some future solutions on how maybe things could go better moving forward. We have 3 speakers today. Our first one is Melissa Winger. She is an amazing mom to a man with a complex medical condition from a rare chromosomal disorder. He's really the inspiration that led to her involvement in the EMSC program. She's one of our FAN representatives, our Family Advisory Network representatives. She's also a member of our Telehealth QI Project Advisory Board, National Pediatric Readiness Project Steering Committee member, as well as a member of the American Academy of Pediatrics Star Center, Committee on Family Partnership and Executive Committee, as well as a patient-centered medical home consumer site evaluator with the Minnesota Department of Health. You will then hear from 2 of our physician leads for our disaster domain, Dr. Brent Kasny and Dr. Deanna Delgrove. Dr. Kasny is a PEM physician at Texas Children's Hospital in Houston, Texas. He works in the emergency center and is director of disaster preparedness for this section of emergency medicine, and serves as a medical director of emergency management and co-chair of the emergency management committee. Dr. Delgrove is a pediatric emergency physician in the Division of Emergency Medicine at University Hospital Rainbow Babies and Children's Hospital. She's a professor of pediatrics at Case Western Reserve University School of Medicine and is also co-PI for ASPR-funded Eastern Great Lakes Disaster Care Center of Excellence. So with that, I will let Melissa take it away.
Thank you. So happy to be here today. And unfortunately, we're not in person, but this is good enough. So thank you for having me. And I did want to thank everybody for putting this together and including our amazing fan representatives. You're going to see us throughout the conference, so it's very exciting. So yes, I am here to share past experiences as part of sort of the disaster planning. And I think we can all agree that the COVID-19 pandemic was definitely in a criteria of disaster. So I think we can go to the next slide. So yes, as Meredith already said, I kind of do a few things around family and family partnerships, parent partnerships. So, and from the wonderful state of Minnesota. So we can go to the next slide. So this is my son in sort of a visual description. So if you kind of think of when we're planning for kids with special healthcare needs, children with complex medical needs, you can just put this slide in your head. So these are the things that are involved with some kids. Mine might be more than most. But if you have this in your head, this is sort of the things that we are dealing with all the time. So my son has a rare chromosome disorder. He is now 25 years old. And he's missing the bottom of his 4th chromosome, and he has 3 of the top of number 6. This caused issues with every single organ system. And so these are the things that we're dealing with all the time. These are all the people, clinics, community agencies, county government, everyone that's involved in his care. So these are all the things that we look to when we're planning for him. So if you can imagine in a disaster, in COVID, in anything that happens, none of these things go away. So none of these things travel with him. So anything that you were planning, not anything goes away. So what happened, of course, during COVID, using that same analogy, is he has all of these to deal with. And he has all of these that need constant follow-up in order to not have exacerbation of different illnesses. So if we can go to the next slide. Our story started before COVID. He was recently moved to a group home. It's just a 4-person home in a neighborhood, and we call it corporate foster care in Minnesota. And before COVID hit, I would visit about 2 to 3 times a week. My son is nonverbal, so it is hard to communicate with them other than in person. So we used to visit constantly. We'd go to his appointments with him, and sometimes he would come home for the weekend. now the lovely COVID hits, and the group home put in rules immediately to protect him and to keep him isolated and try to avoid any contact or exposure to COVID. So this was an abrupt end to all parent visitation. All appointments were canceled, or some were rescheduled to telehealth. And we did request FaceTime calls so I could have eyes on him to see how he was doing, being that he's nonverbal. And so the FaceTime calls were somewhat sporadic and not as much as I would have liked. And even when long-term care started lifting their restrictions, such as nursing homes, assisted living, those did not lift in the group home. They had their own policies, their own rules and restrictions. So this goes on for 14 months. And I was compliant as a mom for the first few months, only because I didn't want him to be exposed. So I was listening to all the rules and regulations to keep him safe. So after about 12 months of this, after not being able to see him for a year, we started struggling. So I think we can go to the next slide and put together a little timeline. So October of 2020, it's a simple ear drainage. Usually that would just mean an ear infection and could be treated. So we're going along with the rules of no bringing him to the doctor. So they had to do virtual care appointments. And at this time, virtual care was my son and a staff person at the group home. They did not have third party able to join in. So as a medical decision maker, I could not join in on these appointments because I was not in the house and I couldn't join in remotely as a third person.
So I have Sarah from PSG has been like pinging me. I was supposed to meet with her this morning at 9. I just did not get to the meeting.
I'm sorry. I'm hearing another voice on my computer, so I apologize for that. Sorry. So in November, so we got antibiotics ordered all virtually. The drainage starts to continue. We still try to manage this virtually.
Just the whole thing. I have
so this continued through
I literally
November, and I'm still actually hearing another voice. I'm not sure if someone's not muted or not. So sorry. So we have going through this whole scenario of the drainage going still virtually. This continued over and over and over. And so now we're into March. So I did became sort of a mother bear, if you will, and took my child out of the group home and brought him to the emergency room. And at this point, the infection was so severe. We did a CT. The infection had spread to his mastoid bone, and his infection had also spread to his skull bone, and he had significant bone erosion. So this would require major surgery. We were admitted to a hospital, and they were going to start surgery to remove basically the majority of his ear canal and the bone behind it due to severe infection. So we also noted during this hospital stay, because I could not have eyes on him through our FaceTime calls, that I just was very concerned he couldn't move his left eye. So his left eye was basically pointing towards the middle, and he really looked like he couldn't move it at all. We were focused on the infection, but someone did take a look at that. And then quickly realized that he had something called sixth nerve palsy, which is that nerve running through the mastoid bone. And basically it would be major surgery to basically reposition his eye. And so that would be removing the eye, taking the muscles off, reattaching the muscle, and there's significant risk involved in that. So this, because we were trying to treat something virtually that shouldn't have been treated virtually, we now he's unable to hear and he's unable to see in one eye. And what the worst thing about this is if you think about the fact that it could have been prevented. And looking at those blanket rules was maybe the right thing to do. We were all kind of just panicking in the beginning to say, what do? We gotta protect kids from being exposed. but then also think of the aftermath of their chronic conditions in that first slide that I showed you. You can go to the next slide. My favorite slide, because this was one of my favorite pictures. This was my son FaceTiming me during one of our meetings. Of course, he dresses in a costume every single day. So this particular day, he was a cowboy. So our pandemic experience wasn't good. However, we didn't get COVID. So some would say, well, that's good. But if you think of all the things that children with special health care needs to go through and what they need to continue to get care for, disaster or not. So if we just kind of think of what should have been done, what could have been done, what we could do better next time. Parents, caregivers are essential. That's something, I mean, I'm a mom, I've always said that, but we needed to be involved in the care. There wasn't staff people at this group home that knew enough to know that he couldn't move his eye. Like, you know, I really think that that's something caregivers know him the best. Just look at our visit types. Is this inappropriate for telehealth? Some are very appropriate for telehealth. Looking at our blanket rules and then balancing it. Risk of exposure for risk of delayed care. So I want to leave you with that adorable picture of my son, Devin, and thank you so much for having me.
Melissa, thank you for sharing that story. I think it highlights what a lot of families have been through during the course of the pandemic, in particular related to the growth of telehealth, specifically within pediatrics that we've seen throughout the pandemic. You know, I can speak from personal experience at Texas Children's. We have greatly expanded our access to telehealth. And an interesting thing to note is that while we've expanded that, you know, these are providers that were not routinely doing telehealth before the pandemic, many of them doing telemedicine visits for the first time, which again, I think highlights some of the unique challenges related to telehealth in this setting. We've seen it grow dramatically during the pandemic. And as Melissa mentioned, it can lead to delays in care, in particular for complex issues or issues where a physical exam will really be instrumental in leading to the definitive care. I do think, though, when we think about telehealth, we have to keep it in the mindset of its potential use for not just the pandemic, but any disasters. And speaking to our experience here at Texas Children's Hospital, what we've seen is that when we have, for example, storms in the Gulf, other things that might be heading our way, we're able to transition a majority of our inpatient visits to telehealth. So despite the fact that maybe roads might be impassable, as long as the power is still going and we have connectivity, we can continue to kind of provide those services that we would normally serve. And I think telehealth, maybe despite some of its downsides, one of the biggest things to come of this pandemic with regards to pediatric care that is going to be here to stay in the future. However, I will say that telehealth doesn't work if the power goes out. And so that leads us to, I think, the next topic that we're going to discuss, next slide, which is the winter storm that we experienced, Winter Storm Uri, from February 13th to 17th of earlier this year. This was particularly challenging for those of us in Texas, with large numbers of people left without power, greater than 9 million left without power. And I wanted to highlight in particular an aspect of this related to technology-dependent children, children with functional and access needs, and how they presented to our facility and how we tried to care for them, and what's grown out of the challenges that we faced during that experience. So we started to see rolling blackouts in our community, which were kind of sold to us as rolling blackouts, but for many cases persisted for 2 to 3 days in certain communities. And during the initial power outages on the west side of town in Katy, Texas, which is about 30 miles west of Houston, Texas, we saw at one of our community hospitals, Texas Children's West Campus in Katy, we saw 12 children that were technology dependent arrive primarily for sheltering via EMS within 2 hours. As you can imagine, this is a large influx of patients that we don't usually expect during the acute onset of a disaster, but really highlighted the needs for these families to have electricity. And one of the downsides to this winter storm was that as a community in general, we were not appropriately prepared for the massive failure of our electrical infrastructure that we faced, and as such didn't have routine shelters that we would have in place. Next slide. So all told, across our entire system, we had 37 total technology dependent children present for sheltering primarily. These parents did not have concerns about the medical nature of need to visit an emergency center or go to the hospital. Their children were overall not sick, just needed an electrical outlet. We very rapidly developed cohorting units positioned at each of our campuses, which would provide very minimal medical oversight, bypass going through the routine emergency center process for admission, and essentially house them and shelter them in place in our facilities. However, of those total 37 children that we saw, 32 of them needed conversion for admission. This was largely due to them not necessarily presenting with all of their medications or supplies that they would routinely present with if they were going somewhere other than their home. So they did not have everything that they would need to provide care for their child ongoing, and as such needed to be admitted so we could write orders for medications, provide additional support. And additionally, some of them were actually found to be ill with increased oxygen requirements and the like. Next slide. While trying to develop these cohort units, we did know that that could be an issue. We frequently have children like this present for emergency medical care, which was really not the case in this situation. Those children sometimes don't have, say, the proprietary power cord for their ventilator. So if you don't have that power cord, which we don't have one that necessarily fits at all of our sites, things like that, we're going to have to then put you on one of our ventilators. And that is a resource need that would then lead to an admission. So we did very rapidly communicate with the Houston Fire Department, HFD, in an attempt to make sure that if they were deployed for any sort of 911 call for a child like this that needed power more than anything else, that those on the ground with EMS could say, let's make sure that we've got all the supplies, backup trachs, medications, power cords, anything that you would need to take care of your child. Let's make sure that you've got that with you on hand and take that with you to the hospital in an attempt to prevent some of these admissions that were not really necessarily medically necessary, but needed to provide them with the appropriate supplies and support. Next slide. So looking back at this, and this is really, I think, kind of sped up some of the things that we started doing after Hurricane Harvey, where we had similar issues in the greater Houston area, in particular with our technology dependent and complex care clinic patients. After Hurricane Harvey, that complex care clinic actually did a number of things to try to research the need for increased disaster preparedness specific to this community. They did focus groups targeting parents of children with special healthcare needs, in particular those that are technology dependent, and identify things that we likely could guess on our own, that a majority of these patients and their families are not particularly prepared for disasters. There was a striking disparity between those that are English speaking versus Spanish speaking and their level of preparedness, with those that are primarily Spanish speaking being less prepared than those that are primarily English speaking. And after Harvey, our complex care clinic has worked to develop a program to improve disaster preparedness for these patients, but this was sped up greatly by the challenges that we faced during the winter storm. Some of the things that we're doing locally are continuing to advocate with our community leaders about the need for shelters to be open prior to events like this, so that families can go to those shelters as a safe place to go with continued and ongoing electrical availability of electricity. In addition to that, what we oftentimes see and hear from those community leaders is that patients that are technology dependent or have complex medical needs don't usually meet criteria for routine shelters. However, those of us that work with this population know that these parents routinely care for these children at home without nursing, without physicians, without medical support, and as such really just need an outlet and a safe place to be during whatever the disaster event is. So we are developing an ongoing program of disaster preparedness education that's going to be embedded into the routine care of these children. So during their annual visits, et cetera, we will discuss these sort of topics with them to make sure that they're adequately prepared for disasters. In addition to that, continuing to work with our EMS partners to make sure if an event like this happens, they're able to transport them with all of their given supplies and take them somewhere appropriate. And then fine-tuning that kind of on-the-fly process that we made related to inpatient sheltering for these children that had lost power. So a lot of lessons learned over 2 past disasters, and really, I think, pushing the agenda of improving pediatric disaster preparedness, specifically for these potentially fragile, very fragile children that live in our community that more than anything need access to electricity to survive. Next slide. And with that, I will pass it off to the next speaker. Thank you very much.
Hello, thank you everyone for listening. Brent and Melissa, I want to thank you so much for Melissa's very powerful story, and Brent for such great examples of what we need to do to prepare. So I'm sort of going to wrap this up with sort of a more general view of children and families and getting prepared, especially for children and youth with disabilities and medical needs. Next slide, please. So when we start to look at our special needs population in the United States and overall what their preparedness looks like, we know that children make up at least 22 to 25% of the population. It varies definitely by state, depending on where you're looking. And 18.5% of those kids actually have special healthcare needs. And this is from our most recent survey, which was in 2017, 2018, on the National Survey for Children's Health. So clearly that data may have changed a little bit. Households in general that have individuals with disabilities tend to prepare less than even other households. And even when we look at our general population, we notice that only about 50% of American families actually have some sort of disaster plan. And when you start to look even more at the critical items that they might need to have, such as water, only 30% of them will have all of the items actually in there, and a lot of them will still be lacking things. So it's really important to understand that, you know, overall in the United States, there seems to be a lack of preparedness for all families across the board. And I think in families with children with special healthcare needs, that we tend to notice that their preparedness may even be more lacking. And it, you know, they're awfully busy with taking care of these kids on a day-to-day basis. So I think it's kind of understandable, but we want to help them be a little bit better prepared. So next slide. So in general, when we look at how do we better prepare for disasters? First of all, one of the things that we look at is why, for example, don't families evacuate? So we just had, you know, Hurricane Ida. Just read a story this morning about a family in Baton Rouge. They couldn't evacuate because they simply didn't have the funds to evacuate. They didn't have the transportation. So again, if you start to look at some of these, you can see that, you know, some people don't want to evacuate for, you know, they're worried about their pets. They're worried about having, you know, transportation issues, things like that. So this slide just sort of gives you a general idea of why people don't want to leave their homes and why they can't evacuate. And I think with just having the most recent hurricane as an example, that sort of tells us why. Next slide. So when we start to think about the unique challenges that sort of exist for the children as demonstrated by Melissa's son. I mean, he has a great number of needs across the board for multiple things, but things to think about are that, when you think about evacuation for children with special needs, if they're have mobility challenges, they're going to have to think about, taking their equipment with them. What does the accessibility look like for shelters if they're going to be going there? As Brent mentioned, I mean, it's challenging to get the transportation. You've got all that equipment that you need to bring. So that's something to think about when we think about the infrastructure that exists. Brenda already mentioned about, telehealth doesn't work without electricity, but then a lot of these kids have special needs and they might need to have equipment that is, needs to be plugged in, needs to have batteries charged, need to have refrigeration. So it's really important to sort of think about these things. And these are the things that you can start to have conversations about when you're in these clinics that tend to, a lot of them will run out of children's hospitals, but they also pediatricians can start to mention these things to their patients in times when they're getting ready to prepare, thinking about how they're going to be transported, whether it's going to be via EMS or whether it's going to be via private ambulance services, or does the family have a specially equipped van if they need special transportation for that. Communication is also another challenge as we think about that, not only for those people that may have be hearing or sight impaired, but also when we think about some of the behavioral challenges that kids have, and it becomes difficult in these disaster situations to sort of understand those. And I think we're seeing a lot of that now as we're dealing with some of the mental health crises and things like that. And I think this was actually illuminated when Melissa talked about her son and the participation in virtual healthcare visits and things like that. And we know that some of the kids with special needs just didn't do well when they were getting schooling over the virtual platforms. So this is just an important thing to think about when we start to prepare. School plans are also important. Children with special healthcare needs and understanding how, when they're at the school, what the evacuation plans might be, what their shelter in place care might be. And we also noticed that when we're thinking about disasters, that the medical care, so the experience with rural healthcare providers, access to specialized treatment at smaller hospitals, all of these things become unique challenges and considerations that we really need to think about so that we can take care of this community. Next slide, please. So through our work at the ASPR supported Pediatric Center of Excellence in the Eastern Great Lakes, we actually have created some great resources that we're very excited to soon be able to share with our community with special healthcare needs through pediatricians, family practice, and advanced practice practitioners, so that we can get this information out to them. We've created both infographics on multiple levels to sort of help people understand how they might better prepare. We've created some short videos on readiness that's going to be translated into multiple languages so that we can hit all communities, as well as translating it into American Sign Language, so that families that might be hearing impaired have access to the same materials. So we're really excited that this is going to be both available to families as well as to healthcare providers, so that they have a better understanding of how to help families in these situations, so that we can be better prepared in the future. Look for these materials to soon be available on the EIC website. We will definitely hope that they're out during Preparedness Month in September. Next slide, please. This is a list of some of the resources that we would encourage you to look at if you have more questions, and we so much appreciate your time. Thank you so much.
Okay, with that, we have plenty of time to take some questions. I see a question in the chat from Catherine Schaefer. thinking about how to create disaster plans for use of telehealth. While the equipment plugged into hospital walls, what are some other options? Zoom via cell phone or other apps that might be HIPAA compliant might be something for consideration. I don't know if anyone has some thoughts on kind of other disaster plans for use of telehealth.
I would say the biggest issue in this case is, ensuring that both ends have access to technology needed. As you mentioned, there are many platforms that do use mobile devices, and so we are able to do telemedicine even on our cell phones and laptops and iPads with both families and our providers. So then, with the exception of the electricity, you still need to make sure you have connectivity with good wireless, either via internet or cellular, which can also be a challenge in these situations. And so, again, it's a challenge and struggle. But what we've also seen is the potential to position providers outside of the area of impact that we know will not likely be directly impacted and could provide televisits for those that either had to evacuate or those that do still have ongoing connectivity. So those are just some quick thoughts that I have related to disasters and the use of telehealth.
I had just one other quick thought about this, and sort of to thinking outside of the box, and the use of community paramedics and looking for them to actually come in and help treat. But what if someone could bring equipment to the home to get connected to a provider? Kind of thinking outside the box, like, what do we need? Do we need telehealth equipment? How can we best do that? And what resources do we have handy to be able to do that? And then I had a thought after my presentation that I wanted to bring up too, is my son's situation was regarding the group home rules. But what actually also happens is there's a fear out there, especially amongst families with special healthcare needs, is even when your child is at home, the thought of bringing them to an emergency room, bringing them in to a doctor's appointment was actually quite terrifying. And you had to really think, do I really need to go? Can this be handled via telehealth? And so there was just an overwhelming fear of keep your child away from any hospital, any doctor's office. So families are struggling with deciding telehealth versus going in for in-person care as well. So goes far beyond rules as well. It's how are we educating our families on what is appropriate to bring in and what do you need to be seen for?
Yeah, Melissa, I really want to thank you for that, because I think that, some of the challenges that I have noticed is that, even on a day-to-day basis, it's hard to just go to a regular doctor's appointment for some of these families. I mean, there's other kids to bring along. A lot of families live in more rural areas just because of cost of living. That makes their broadband access challenging. So, just understanding the day-to-day challenges is important, and this pandemic has just highlighted how much we need to really work to sort of knock down some of those barriers that exist and really change the dynamic for everybody, whether you're urban or rural, and getting broadband access, and really, just even doing a check-in telehealth and saying maybe this is more appropriate to have, in-person visit despite the pandemic scares and things like that.
Yeah, I think those are excellent points to make that I think really highlight the need to not just increase access to telehealth options, but increase access to in-person visits as well. So I'll give you a couple of examples of what we've seen here, particularly related to the pandemic, is obviously a need for increased access to care, whether that's telemedicine, urgent care visits, EC visits, primary care physician visits. And we've added virtual urgent care to our urgent care kind of menu of options at Texas Children's. So you can access an urgent care physician for a virtual visit. And just Sunday, we had our record number of those, and in one day saw over 140 kids in a virtual environment through that urgent care process and piece. We're not doing that in a silo. We're also increasing access to care that we know is the best care, which is your pediatrician's office. And so instituting hours on Saturdays. So we had 36 practices that were open all day Saturday, which is a little bit unusual for us. And one of those practices was also open on Sunday. So increasing that access to in-person visits, increasing that access to telemedicine, and getting creative with some things that I would say maybe fall under the kind of purview of telemedicine. But, you know, for example, for our Texas Children's pediatric patients, we have an e-visit process where if they have maybe mild or minimal symptoms that would not routinely cause them to seek care in an emergency center, urgent care, their pediatrician's office, but primarily have concerns for COVID and the need for testing, they're able to go onto our patient portal via Epic's MyChart, fill out a brief questionnaire that gets reviewed by a physician, and then a test gets ordered at one of our drive-through locations. So again, hoping to ease some of the burden of the need for inpatient visits for things that previous to the pandemic, parents probably would have cared for on their own at home without seeking care, you know, mild cough, congestion, low-grade fevers. But because of this added kind of burden of needing to test for COVID for release back to schools or daycares or what have you, really needing to expand all of our options. And what we're seeing is that despite all these significant kind of things that we've done to expand access to care in our emergency centers and urgent cares, we still have been inundated in our emergency centers with low acuity patients, primarily requesting COVID testing.
Thanks, Brent. We have another question in the chat from Tamara. So I would like to know if any of the planning is happening in coordination with key state agencies such as developmental disabilities or Katie Beckett waiver programs. Those entities with their case management teams can be key partners with families, hospitals, et cetera, for helping families prepare more thoroughly than what they can do on their own.
That's a great question. You know, I think the work that we're doing that I'm involved with our complex care clinic population here has definitely involved all matter of public health entities, both those involved and engaged in shelter creation, but also those that check some of the boxes that you mentioned in your question. And I really think it requires that community of care and community of providers to, you know, address some of these issues that develop during disasters. And again, something that we've highlighted through the AAP's Council on Children in Disasters and the EIIC's disaster domain is that really key crux of that key position of engaging with public health in all things disaster related. You will be engaging with them during the disaster, and we know it's always better to know these folks ahead of a crisis as opposed to during a crisis. So excellent point, and I highly recommend that folks engage with those public health entities as they look towards developing similar type of plans and interventions.
Brent, I might actually add one resource too that is home health care agencies have some disaster plans in place too, and understanding how they engage with equipment supply, et cetera, can be extremely important, especially medications in advance and things like that.
I also would think opportunities are something we have to think about. And when do you have the opportunity to have these conversations? I think a lot of it happens at the hospital level when you're going home. And I think there's hesitancy because just getting a family ready to go home with a special needs child, and then you get staff who say, we really don't want to scare the bejesus out of them. And then think about, okay, if your house gets hit by a tornado, you're going to want to do X, Y, and Z. However, it is a very important conversation to have, and the right discussion about, This will likely not happen. However, we want you to be prepared as possible to have that discussion on what you should do in case of an emergency. Because likely that discussion hasn't happened and the family is going to get into an emergency and go, I wish I would have known this. I wish I would have known that. So opportunity is good. So hospitals at discharge, great time to have a conversation. Primary care, anytime that you can have these conversations. And also don't assume that someone else had the conversation. Oh, I'm sure they were taught about that at discharge. So just those things.
Melissa, great points. I think, what we saw, which I thought was fascinating during these focus groups that we did, was that despite the fact that vast majority of these families had been impacted by Hurricane Harvey, and despite the fact that they had recognized that the likelihood of another event like Harvey was likely to occur in our region in the near future, in the next 5 years, they didn't feel like they needed to have a disaster plan in place. And so I think that is a key piece of education, is really reaching out to these families and stressing the importance of a plan, importance of an evacuation plan, backup plans if your house loses power to go to a family member's home, et cetera, and having the supply stations for your child so that you can leave with them quickly if you need to leave your home.
I think that's all great points. And I do see one more question from Jane. Is there a way to prepare for caregiver support and needs during a disaster?
So this is a really important point. And I think that, caregivers, and one of the things that we noticed, Melissa mentioned, the group home and the group home rules, and, the reliance that families have on support services to come in from home health, whether it be, nursing or, just sort of respite care, things like that. That's another great conversation to have. I think we often think as caregivers, whether you're caring for a special healthcare needs child or, elderly adult or something like that, we often overlook the own caregiver's needs. And I think those are just other important conversations to sort of put into the whole planning process, is to, what are the caregivers' needs on a day-to-day basis, and what are we going to do if things begin to change in the disaster situation? Because as we saw with COVID already, we lost a lot of people in the home health environment, staffing shortages, things like that, and families were really left in a lurch. So again, it's an important piece of the conversation to realize that those things are going to happen, and that those home health care providers are not going to necessarily be available. Schools will be closed, things like that. So again, it's all part of the planning process, and on a day-to-day basis, it's really difficult to sort of even imagine those things happening. But I think if a little bit of planning actually helps things go a little bit more smoothly in the future, if you've even thought about those scenarios and had those conversations.
Wonderful. Thanks, Deanna. I'm not seeing any more questions in the chat. We do have 2 more disaster-focused talks, 2 breakout sessions, one later today and one tomorrow. We encourage y'all to join us again, and we will speak a little bit more about disaster resources and planning. At this point, we're going to move into a fun little break and fun activity, a scavenger hunt that will be led by NEADARC. I also want to encourage you to visit our partners. They have some videos on updates from our federal partners, and please go and visit those rooms and take a look. So with that, I want to say thank you to Melissa for sharing your story. Thank you, Dr. Kasny. Thank you, Dr. Dahlgrove. Really appreciate your insights.